In this video lecture, we'll be discussing how our behavioral healthcare system and the more general healthcare system is financed. That is, how is healthcare paid for? In addition, we'll be talking about cost containment and how that might affect the care that's provided. Before we discuss specific ways of paying for healthcare, I'd like to talk about the ways that broad healthcare systems are run or financed. In other words, how do countries organize their healthcare system? Well, there are really 4 ways that healthcare systems can be organized, and examples of each of these ways of organizing healthcare is present in the United States. So let's talk about each one individually. The first way to organize a national healthcare system is through nationalized medicine. In this type of system, the government actually runs and owns the hospitals and pays the doctors, who are government employees. An example of a country that runs their system this way is the United Kingdom. The British Health Service owns the hospitals and pays the physicians and nurses and other staff to provide health care to their citizens. The example of this type of approach in the United States is the VA system. The U.S. government owns the VA hospitals and pays the VA physicians as government employees. The second way to organize a national healthcare system is through national health insurance. In this type of system, hospitals and physicians are privately run. However, the government provides a national insurance plan that covers its citizens and pays for their health care. Examples of countries that run their system this way are Canada and Israel, as well as a couple other European nations. The example of this type of approach in the United States is Medicare and Medicaid programs. The government doesn't own the hospitals nor employ the physicians, but the government does pay the bills for the citizens enrolled in the program. The third way to organize a national healthcare system is regulated fee-for-service or managed care medicine. In this type of system, the healthcare and funding for healthcare is entirely private. The government's role in this type of system is to largely set the ground rules and make sure that they're enforced. Minimum standards of care and benefit plan structures may be required and regulated. But again, the insurers are private and the healthcare provided is private. Examples of this type of approach to running a healthcare system are most of the countries in Europe, and really many countries in the world. The example of this type of approach in the United States is the Affordable Care Act, or Obamacare. The Affordable Care Act dictates certain standards and structures that private insurance companies need to offer, but it is entirely up to the private insurance carriers to decide whether they want to participate and how much they charge. They are in competition for enrollees, thus they have incentives to have lower premiums. The fourth and final way to organize a national healthcare system is unregulated fee-for-service or managed care medicine. This is the fully free market-based system where individuals, insurance companies, and healthcare providers can pretty much do whatever they want. Prior to the Affordable Care Act, which was passed in 2010, most of the United States fell under this type of structure. Very few countries, except some resource-poor or smaller third-world countries, use this approach today. So as you hear politicians talk about socialized medicine or how the U.S. healthcare system should be structured, hopefully this brief list of how countries across the world structure their healthcare can help you understand the debate in a more informed way. Okay, so drilling down from how entire healthcare systems are organized to how healthcare is typically delivered to an individual enrollee, there are a couple broad ways of doing it. The first way is fee-for-service, and this payment method is pretty straightforward. When a particular medical service is performed by a physician or other healthcare provider, the patient or their insurance pays a fee for that service. The more services that are provided, the more the patient and insurance pay, and the more revenue the physician receives. Services may include lab tests, medical procedures, and visits. But what is the incentive for the physician under this arrangement? It is simply to provide more services and bill for them. For this reason, traditional fee-for-service arrangements have been and are in the process of being phased out. Most care is now delivered under the second broad type of delivery structure. That is a managed care arrangement. Formal managed care arrangements started many decades ago by provider groups that banded together to provide a comprehensive set of healthcare services. These health maintenance organizations, or HMOs, provided whatever care the individual enrollee needed, from outpatient visits to hospital care. The hitch in this arrangement was that the individual enrollee needed to go to the HMO's healthcare providers, and only in emergencies could they go outside the HMO's network of providers. When sick, an enrollee couldn't just go see a specialist or have any medical treatment without the consent of the HMO. Typically, the HMO primary care physician monitored the patient's health and served as a gatekeeper for other service providers. So the incentive for the physicians in the HMO was actually to make sure the enrollees did not use services, or rather, were healthy. Thus, the HMO or managed care organization would often provide funding for services beyond medical care, such as gym memberships or other wellness programs. Other types of managed care arrangements developed over time. Some of those are listed here, such as point of service programs or preferred provider organizations and exclusive provider organizations. These are just different structures for an enrollee's care to be managed. For example, in preferred provider organizations or PPOs, a provider is listed with the PPO where patients can go seek medical help and pay a lower amount as a copay. If they go outside the network, the PPO would still cover most of the costs, but the enrollee would still have to pay more. This gives more options for the enrollee, but at a cost. Managed care arrangements continue to evolve, and new structures will no doubt develop in the future. There are a number of sources for financing healthcare in the U.S. What I want to do now is talk about several principal sources of financing. First, there are government programs including Medicare and Medicaid. Secondly, there's private insurance, which oftentimes is provided through a person's employer. Finally, there are out-of-pocket payments for healthcare, where individuals cover their own costs for the care they receive. Let's look at these in more depth. The first government program that we need to take a look at is Medicare. Medicare was enacted in 1965 and was based on the best insurance plans of that time. Unfortunately, it hasn't evolved as quickly over time as some other private types of insurance, and thus may not be the best structure to provide health insurance anymore. Nevertheless, millions of Americans receive health care that is paid for by Medicare. What's critical to understand about Medicare is that it is 100% federally supported. That means states do not share in the cost of Medicare, and the federal government has the burden to provide all of the funding for the program. When it was first started in 1965, Medicare eligibility was open only to older adults. It was designed to help older adults pay for needed health care after they were no longer covered by employer-supported health care insurance. However, in the 1970s, during the Nixon administration, the Medicare program was expanded to include several groups of young disabled persons who could not obtain insurance any other way. Today, about 2/3 of Medicare enrollees are older adults, and about 1/3 are disabled young people. Medicare is structured into several parts. Part A covers major medical and hospital costs. Back when the program began in the 1960s, most Americans received the bulk of their health care in facilities like hospitals. Thus, Medicare was structured to primarily cover those costs. Funding for Medicare Part A comes from designated payroll taxes. When you receive a paycheck, you might see a tax called FICA. That is essentially the Medicare tax for Part A. Medicare enrollees do not pay any premium for Part A benefits. Medicare Part B covers most other medical services such as outpatient, physician visits, home health care, and other non-facility-based care. Medicare enrollees pay a premium to enroll in Part B that can fluctuate from year to year. Because in 1965 most healthcare costs occurred in facilities, the creators of Medicare did not anticipate large Part B costs for the government. For that reason, they did not create a special tax for Part B government obligations, but instead funded Part B from federal general revenue. As outpatient procedures have developed, Part B has become ever more important for the care of enrollees, and costs to the federal government have increased tremendously. And again, the costs of Part B come straight from federal general revenue, that is income and other taxes from all citizens. Medicare Part C was added in 1997 and is called the Medicare Advantage Program. It creates an option for Medicare enrollees to join an HMO or other managed care organization. The idea was to give Medicare enrollees options as to what type of delivery structure they wanted. Medicare HMOs limit what providers an enrollee can go to, but may also have a broader array of wellness benefits. Again, the idea is to give options and choice to Medicare enrollees. Medicare Part D is the pharmacy program, and that was started in 2005. Up to that point, no pharmacy benefits, that is, medication or drugs, were covered by Medicare, and many older adults had to spend down in order to be eligible for Medicaid pharmacy coverage. The program is evolving, and several complaints about the implementation of Part D, including the Part D donut hole, have been addressed by the Affordable Care Act that was passed in 2010. Another government healthcare program that serves millions of Americans is Medicaid. Like Medicare, Medicaid was also enacted in 1965 and was based on the best insurance plans of that time. One big difference between Medicare and Medicaid, however, is that while Medicare is 100% funded by the federal government, Medicaid is partially federally supported and partially state supported. It's oftentimes a 50-50 split with regards to the cost for the program, which is what the case is for Florida. But some states may have a different split arrangement with the federal government. What this means is that the state has an incentive to try to shift people off Medicaid and onto Medicare. So if a Medicaid enrollee meets requirements for Medicare eligibility, the state might actually pay the Medicare premiums for that person in order to shift the costs to the federal government. Eligibility for the Medicaid program requires a couple of things. First, the program is means tested, and thus the person needs to be indigent or economically poor. What this typically means is that the person must be at or below the federal poverty level. The poverty level is determined by various factors such as a person's income and the size of their family household, and is currently about $12,000 for individuals and about $25,000 for a family of 4. The second eligibility requirement is that the person must meet the requirements of another program, such as being disabled or being eligible for the Back to Work programs of the federal government. Medicaid also covers care for other specially defined groups, such as children in foster care and other citizens with special needs. The structures for healthcare delivery in Medicaid range from complete fee-for-service to more controlled managed care insurance plans. However, most states are shifting away from fee-for-service to almost exclusively managed care plans as costs continue to skyrocket. The vast majority of U.S. citizens receive support for healthcare costs through private insurance. With the passage of the Affordable Care Act in 2010 and its implementation in the years following, several changes have structured the private insurance market in the U.S. The Affordable Care Act regulates for-profit and non-profit insurance carriers, many of whom are contracted to provide health care by a person's employer. The ACA requires transparency in plans offered on health care exchanges so that potential enrollees can compare plans of different insurers. The ACA also requires that these private insurance plans do the following. First, put no annual or lifetime limits on coverage. Second, have no exclusions for pre-existing conditions, allowing millions of individuals with chronic conditions to have flexibility in insurance carriers. Third, to allow children to remain on their parents' health insurance up to age 26. Fourth, to provide limited variations in price to make comparisons easier. Premiums can vary based only on age, geographic area, tobacco use, and the number of family members. Fifth, allow for limited out-of-pocket expenses. Sixth, to not discontinue coverage, something called rescission, except in cases of fraud. Seventh, to cover certain defined preventive services with no cost sharing. And finally, to spend at least 80 to 85% of premiums on medical costs, which means the insurance carriers are limited to 15 to 20% profit. The ACA has brought millions of U.S. citizens into the private insurance market, but certainly could be improved on. It's unclear whether current political forces in Congress will allow that, however. Other types of private insurance include Medigap insurance, which covers procedures and costs not covered by Medicare. Popular Medigap plans include those provided by Blue Cross Blue Shield and AARP. Long-term care insurance is another growing sector in the private insurance market. These plans cover care that is not acute medical care, but rather services for chronic conditions. Thus, nursing home care and home health care for ongoing chronic illnesses would be covered by a long-term care insurance plan. Currently, the biggest provider of long-term care support is Medicaid. You may have heard of the term spending down, which is when an older adult or other enrollee spends down their assets to become eligible for long-term Medicaid coverage. This is not an ideal approach to long-term care, but it's the only option for many people who have not purchased private long-term care insurance. Finally, private disability insurance can typically be purchased through employer benefit plans and can be a critical supplement to Social Security disability plans available to all U.S. citizens. Again, the private insurance market is the primary source of financial support for acute and long-term care in the U.S., and the Affordable Care Act and other regulations not only promote the use of private markets, but provide structure so that U.S. citizens can make more informed decisions about which plan to select. Out-of-pocket payments for health care are another source of healthcare financing. Some individuals and groups essentially self-insure through a variety of tax-free savings options. Flexible spending accounts can be set up through an employer to allow pre-tax money to be saved for anticipated health costs. The money deposited in these accounts, however, must be spent by the end of each year. Another option for saving for healthcare needs are health savings accounts, where money can be saved for future healthcare needs. Again, both of these are a kind of self-insurance program, and if an emergency or other healthcare need occurs, the individual must pay for it out of these accounts. There are some additional legal issues in healthcare cost containment. The first is utilization review. As I've said previously, utilization review is the evaluation of the necessity, appropriateness, and efficiency of the use of medical services and facilities. It is almost entirely a record review of what types of services were provided for what cost, and it assumes that patients are not able to judge the appropriateness of the services provided for themselves. This goes back to the old paternalistic or therapeutic privilege idea, where healthcare professionals know better than the patient what is needed. Utilization review, however, is used extensively under Medicare. When Medicare was started in 1965, patients just did what the doctor said, and thus Medicare, which was the insurer who paid for the services, wanted to make sure that the physicians were providing the appropriate services. The bottom line, as I said when I was discussing record keeping a few modules ago, is that as a professional, you need to maintain good documentation of records. Poor record keeping suggests poor care. Another legal issue in healthcare cost containment is the liability system and medical malpractice. Cost containment in the healthcare context is not always compatible with good quality care. An illustration of how these factors relate to one another is Professor William Kissick's Iron Triangle of Healthcare. It's illustrated in orange on this slide and involves the balance of the quality of healthcare with access to healthcare and the cost of healthcare. Changes in any one of these three can directly impact the other two. For example, an increase in the quality of healthcare, in other words, putting more resources into improving healthcare, can increase cost and may also result in a decrease in access for some people. Increasing the access to healthcare, that is, giving more people the opportunity to receive healthcare, could also increase cost, but may decrease the quality because there are only limited healthcare resources. Decreasing costs, rather removing resources, could result in decreased access and poorer quality of services. Now, the relationships don't always have to behave in the way that I just described them, but the key is recognizing that these three factors are greatly interrelated. And when politicians discuss modifications to our healthcare system, this can be a useful way of trying to understand the potential impact of those modifications. Poor quality healthcare can, of course, result in lawsuits. Courts have typically placed responsibility on physicians providing the care rather than on the managed care organizations or insurance companies that are paying for the services. An example of this is the Wickline case. Ms. Wickline was hospitalized for circulatory problems and needed extra surgery. While the surgery was approved by her insurer, Medicaid, the physician's request for 8 post-operative days in the hospital was not approved. Instead, the Medicaid nurse reviewer allowed only 4 post-operative days in the hospital. Ms. Wickline was discharged to home after 4 days, and later, due to complications, her physician had to amputate her leg. Ms. Wickline sued the state of California, Medicaid, and her physician. Ultimately, an appeals court found that the responsibility resided with the physician because he did not challenge the decision by Medicaid. Thus, the physician was the liable party and not the managed care organization, Medicaid. This trend to hold providers responsible instead of insurers may be shifting, however. Recent state legislation and even federal Patients' Bill of Rights may allow lawsuits against insurers and managed care organizations to be more successful. Nevertheless, if you are a service provider, you should provide the services you feel are necessary regardless of payment. Otherwise, you could be liable. I want to briefly talk about disability programs. These are very important sources of funding for important services for some of the most vulnerable people in our society. Unfortunately, they also have the potential to be abused by individuals who falsely claim that they have a disability. The two main public programs are Social Security Disability Income, or SSDI, and Social Security Income, or SSI. These programs provide payments to support disabled persons who cannot support themselves through employment. In order to be eligible for support, the following must be shown. First, the person must have worked at a job that has paid Social Security payments, that is, payroll deductions, for a certain amount of time. Second, the person must be totally disabled for performing any work for a time that has lasted, or at least is predicted to last, at least 12 months. And finally, the inability to work must be caused by a medical condition. Mental health conditions are valid as medical conditions under the disability law. So as a behavioral healthcare professional, you may encounter individuals who are receiving disability payments or who may be seeking to receive disability payments. Regardless of what we sometimes might think, healthcare resources are not unlimited. And indeed, those resources are rationed every single day. Sometimes the rationing is based on whether service is paid for by an insurance carrier or not. But there are a number of other studies that show a de facto rationing that is occurring on the basis of bedside decisions and actions by nurses and physicians. Professionals are deciding with patients and families whether extraordinary treatments should be started or continued, given the probability of success, the increased costs involved, and the perceived need of resources for other people and in other healthcare areas. This type of rationing, however, is not very systematic and oftentimes may not seem very fair. Some privileged individuals might receive special care and have access to things that most other people don't have access to. So, because we have limited healthcare resources, should we be more formal and systematic about rationing healthcare by certain characteristics? For example, should we limit healthcare options for older adults? After all, they're in their declining years, and thus the bang for the buck in carrying out an extraordinary medical procedure such as heart surgery or hip surgery may be much lower than shifting those resources to a younger person who has more life years ahead of them. Or is this inappropriately discriminatory towards older adults? We could also limit access to healthcare resources based upon behavior. For example, certain diseases that are clearly the result of a person's bad behavior, such as lung cancer resulting from smoking, or cirrhosis of the liver resulting from extreme alcohol use, could be eliminated from priority surgery lists, or charged at twice the rate of other surgeries. This is a difficult issue. We don't have unlimited resources, but it's hard to decide who deserves the resources we do have. This concludes this video lecture on healthcare financing.